Okay, so today we will be discussing common reproductive issues. Okay, so the first topic that we're going to discuss is amenorrhea. Amenorrhea is absent menstrual cycles or absence of meniscus during reproductive years. You can have two different types of amenorrhea. You can have primary, which means that they have not had a menstrual cycle yet. It is delayed. So if they have not had a menstrual cycle by the age of 14 to 16, then this can be diagnosed as primary amenorrhea. Most commonly, it's caused by structural abnormalities. It could be absence, secondary hormone traits, malnutrition, if they're anorexic or not getting proper nutrients, then that can cause it. Also obesity or genetic chromosomal problems. So basically is what you need to take away with primary amenorrhea is they have not had a menstrual cycle yet. It's delayed by the age of 14 to 16. With secondary amenorrhea, they have had normal menstrual cycles and now they're not having a menstrual cycle. They're having absent periods. That's amenorrhea, secondary amenorrhea, I'm sorry. The most common cause for secondary amenorrhea would be pregnancy. If they're pregnant, they stop having meniscus, or lactation. If they're breastfeeding, lactating, they may have absent menstrual cycles. Also, medications, birth control, as we discussed in our previous lecture, birth control can stop meniscus. If they're older, they could go into menopause, which could cause amenorrhea. And we're going to talk about menopause a little bit later. Or if they have any disorders such as thyroid, polycystic ovarian, pituitary tumors, and there's others, but those are the most common. So we screen for amenorrhea. We screen for that by asking them their menstrual history. So for instance, if it's a young female or an adolescent who comes in presenting with problems, we're first going to ask, have you started your menstrual cycle? If they say yes, then we're going to ask them what age they started their menstrual cycle at, how often, like what is their cycle length, how many bleed days do they have, when was their last menstrual period. We're also going to gather a sexual history. Are they sexually active or are they not? Also looking at their nutrition and exercise status. I didn't mention it before, but you can also have athletes that excessively exercise, and that can cause amenorrhea as well. And then with the nutrition, remember that it can cause, if they're malnourished or obese, can be a problem. We're also going to look at some labs. We're going to get just a basic CMP, looking at their basic chemistry. We'll look at their follicle stimulating hormones, which is their FSH, their luteinizing hormones, which is their LH, and then look at a prolactin and a thyroid stimulating hormone level, because as I mentioned, that thyroid disorders can also cause amenorrhea. Some other diagnostic tests that you may see ordered would be a CT scan or MRI to look for any structural abnormalities. The treatment for primary is going to usually be estrogen, and estrogen is used to stimulate ovulation. And when they stimulate the ovulation, then obviously meniscus occurs. For secondary, they do medroxyprogesterone to start the bleeding process, the shedding of the uterus. Alright, so we discussed amenorrhea. Now we're going to discuss dysmenorrhea. What do you think whenever you think dys? Dys means difficult or painful. So it's a painful menstrual cycle. This pain can be described as cramping, nausea, vomiting, bloating, Some people have dizziness or headaches. Some people will say they have weight gain or food cravings, and even breast tenderness. There are two types of dysmenorrhea as well. Primary dysmenorrhea occurs usually within the first 3 years. So if you remember primary as first, it happens first. That's a good way to remember it. So it usually occurs in the first 3 years after the menstrual cycle start. With primary, they have painful meniscus, but they have normal pelvic anatomy and physiology and normal ovulation. So it can be caused by excessive production of prostaglandins. It could also be caused by psychological stress and anxiety, which is more common for the stress and anxiety. Because if you think about when in adolescent years is usually high school age females are the ones that are starting it. That's the first 3 years. And it's high school, it's stressful, they have a lot of anxiety and they don't know how to cope with that stress, and so that's a big cause of the primary dysmenorrhea. With secondary dysmenorrhea, it usually occurs later on in life and there is a problem. So primary, no problem. Secondary, there is a problem. Usually with secondary, the problem is going to be, the most commonly is going to be endometriosis. They can also have pelvic inflammatory disease, uterine fibroids, any scar tissue, ovarian cyst or polyps. If they have any infertility issues, a lot of times they have dysmenorrhea. Some screening things that we can do would be basically the same as the amenorrhea. We're going to look at their medical history, their sexual history, their menstrual history. They're going to get a pelvic exam. We usually treat dysmenorrhea with low-dose birth control or contraceptives. I'm sure that somebody's heard that, like, a female starting their menstrual cycle, or they said that they had a lot of cramping and so they were placed on birth control, and that doesn't mean that they are necessarily sexually active. It just meant that they were having such severe dysmenorrhea that that was a treatment choice, and it kind of killed two birds with one stone. It acts as a preventative against pregnancy, and it also acts to help diminish the signs and symptoms that they're having with their menstrual cycles. Also, they treat it with NSAIDs. NSAIDs are non-steroid anti-inflammatory drugs, and so they decrease the inflammation, which decreases the pain. A lot of people will disagree that NSAIDs are bad to take while you're on your menstrual cycle because that could increase the bleeding, but that's actually not true. NSAIDs can actually slow down the bleeding, and it will tremendously help with the pain. A non-pharmacological intervention that they could do would be heating pads or increase their physical activity. So dysfunctional uterine bleeding is random bleeding. So if you have a female who is normally a 28-day cycle patient, and 28-day cycle, remember, means from the start of the first sign of bleeding to the start of the next period or menstrual cycle. There's 28 days in between. So dysfunctional uterine bleeding can mean that they have their normal menstrual cycle, and then in between that 28 days, they have like a random period of bleeding. They're not ovulating, but they're bleeding. It can also mean that they have just a prolonged bleeding time, meaning that most females have a set like 7 days or less bleeding time. And so if they bleed for like 10 or 11 days or longer, then that can cause anemia, and that can be a problem. So dysfunctional uterine bleeding, it can be excessive, it can be frequent, or it could be prolonged bleeding. It's usually caused because of a hormone disturbance, but as I mentioned, if it is persistent or excessive, then it can cause anemia. Also, problems that have been contributed to causing dysfunctional uterine bleeding would be tumors, cysts, or obesity. And do know that this bleeding is usually painless. I know we just talked about dysmenorrhea, but this is different. With these bleeding periods, it shouldn't be painful. There are two terms associated with this condition. It's menorrhagia, which is excessive or prolonged bleeding with meniscus, or metorrhagia, which is irregular, frequent bleeding, but it's not excessive. So menorrhagia is excessive, metorrhagia is not excessive. Some screening that we're going to want to do is we look at their H&H levels and make sure that they don't continue to trend down. We would also want to do an endometrial biopsy, do a vaginal ultrasound to look for the bleeding or the source of the bleeding. The treatment is ultimately we're going to treat the underlying cause. So we have to find why they are having this blood loss. A lot of times we are going to give fluids. We may have to give a blood transfusion. They'll be on NSAIDs or prostaglandin inhibitors. We may put them on some oral contraceptives, maybe estrogen and progesterone. I didn't mention it earlier, but one of the screening processes or interventions that we would be monitoring would be their pad count. So anytime you have somebody that has excessive bleeding or that's in postpartum, if you're worried about hemorrhaging, we always will weigh a dry pad, and then we'll weigh the actual pads. And the actual pads that are saturated we will weigh, and so that gives us about how much blood loss that they're having, and that's a good way to keep track. And we'll count how many pads in an hour that they're having to use, and if it's excessive, then we will be measuring them, as I mentioned. All right. Now we get to talk about PMS, premenstrual syndrome, or also known as PMS. I'm sure everybody in the class has either had it or seen somebody that has had it. It is a wide range of recurrent symptoms. It's very emotional, moody time. It usually happens a couple days to a week before meniscus starts, and then it stops as soon as meniscus does occur. As you can see in the pictures, the slide just cracks me up because the female is screaming, "I do not have PMS." These patients or females get very defensive, that nobody likes to be told that they have PMS, but it is a real thing, and there's actually no known cause. They have linked it to a hormonal imbalance. They think that it's a hormonal imbalance with decreased estrogen and progesterone, which causes an increase in aldosterone, which increases bloating and increases just the moody response. The picture down here that says my typical day of PMS. Number 1, eat all of the food. 2, cry about it. 3, get mad at all people. 4, cry about it. 5, repeat. I mean, this is how some of these people feel. It does seem to hit more adolescence years, or maybe it just evolves like adults learn how to cope with it more, or they're more aware of it. But it does seem that adolescents are unaware of their bodies, and it is a very moody, emotional time for them. The treatment is a healthy diet. They need to avoid caffeine, exercise. If they are a smoker, they need to stop. Birth control can help with this, and as well as NSAIDs can also be another alternative. There is a more severe variant of PMS. It's called premenstrual dysphoric disorder, or PMDD. In order to actually diagnose with PMDD, it is more severe. They have to have 5 of the PMS signs and symptoms to be diagnosed with PMDD. Okay, so to diagnose PMDD, they're going to ask the patient to chart symptoms for 2 cycles. They'll ask them to chart their anxiety, which includes difficulty sleeping, any mood swings, clumsiness, any cravings that they have, such as sweet or salty foods, depression, if they have any low self-esteem, anger, if they get easily upset, hydration, which includes weight gain, any abdominal bloating, breast tenderness, or other, which includes hot flashes, cold sweats, nausea, any diarrhea or constipation, if they have any aches or pains, or even acne. And according to the American College of Obstetricians and Gynecologists, the ACOG criteria to diagnose PMDD, they must have at least 1 affective and 1 somatic symptom before menses. And they have to have 5 total signs and symptoms in order to be diagnosed. But one of those must be affective and 1 somatic symptom. And it has to be at least 5 days before menses. This is a video that if you want to watch, it's about menopause. It may be helpful. Okay, so menopause. Menopause also is the cessation of menstruation. So it's a normal process in which your menstrual cycles stop. There is a process of going through menopause. The average age for a woman to go through menopause is 52. So it comes later in life, and there are signs and symptoms that we're going to talk about, but it's not considered complete until they've had 1 year of amenorrhea, meaning 1 year of no menstrual cycles. After they've had 1 year, then they have went through menopause. They are in menopause. So the impact of menopause on the body, on the brain, it can cause hot flashes, sleep, mood, or memory problems. For the heart, it lowers the levels of HDL, which, remember, your HDL is your good cholesterol. You want it high, so it lowers it, which when your HDL is lowered, the problems that can cause is cardiovascular disease. Can increase your chances of blockage. The effects that it has on menopause. The effect menopause has on your bones is bone density loss. It puts them at increased risk for osteoporosis. How the impact of menopause on the breast is the duct and gland tissue is replaced by fat. Your genitourinary, due to the lack of estrogen, you have vaginal dryness, you can have stress incontinence, or cystitis, which is a bladder infection, more frequent urinary tract infections. Your gastrointestinal impact is going to be that they have less calcium absorbed. Going back to that, it kind of circles back to bones. If they have less calcium that's absorbed, they're going to be at increased risk for fractures, increased risk for the osteoporosis. The skin may become dry, thin, collagen decreases. And just an FYI, the primary cause of hot flashes and night sweats is caused from the estrogen deficiency. So we treat menopause with water-soluble lubricants or estrogen creams, and that's to help with the vaginal dryness. We can also do hormone replacement therapy with estrogen. However, your hormone replacement therapy, that puts you at a huge risk for developing breast cancer or having even the dysfunctional uterine bleeding. If we do progesterone, progesterone actually decreases the risk of uterine cancer. And in addition to that, some non-pharmacological treatments would be just having a healthy diet. Some supplements would be to increase their calcium and vitamin D, because remember, they're at risk for bone fractures and osteoporosis. And we probably, with that risk factor, we would want to get some bone scans, some bone density scans. Okay, so now moving on to breast disorders. The most common complaint is going to be breast pain. They may have found a breast mass, or they may have noticed any nipple discharge. This is a chart out of your book that describes the benign breast disorders. This would be a good thing for you to review. Okay, fibrocystic breast changes is also known as benign breast disorders. These patients present with lumpy, tender breast bilaterally. It's usually a dull, achy fullness feeling, and they can possibly have clear or yellow nipple discharge. As you can see in the pictures, this is what a fibrocystic breast disease looks like. You see the healthy, and then if you look, I'll point at the patches. These are fibrocystic breast changes. So the response of breast tissue to monthly estrogen and progesterone levels, it is the most common breast disorder affecting women between the ages of 20 to 50. It is very rare in postmenopausal women. It is benign, meaning that it's not cancerous. And it does not necessarily increase their risk for having breast cancer. So please remember, these patients may feel these changes, and I mean, as you can see, I could see how it would be scary to feel that, but this condition is bilateral, and it does not increase the risk for breast cancer. It is benign. To diagnose this or differentiate between breast cancer or fibrocystic breast disease, they're going to need to do a mammogram and possibly an ultrasound. Your fibroadenomas are benign solid breast tumors. They're very firm, smooth, rubbery, or hard. They are well-defined shapes. They're usually painless, and they can vary in size. You can have granular and fibrous tissue, which usually occurs in women between the ages of 15 to 35. The treatment for these is going to be just watchful waiting. They may do surgery, which is a cryoablation, which means a cryoablation is extreme cold to destroy the tissue. But usually on these, they're like, it's little fibroids in your breast, and it's tissue, and they'll just watch it. They may do more frequent mammograms, or we need to educate patients on the importance of doing self breast exams and make sure that they follow up every year with a provider. Some people are a little bit more aggressive and they want them to follow up every 6 months. But basically, we're just going to watch and wait, and if you notice any changes, then that's when it becomes alarming. Mastitis is an infection or inflammation of the breast tissue. You can have lactational or non-lactational mastitis. Lactational is obviously they're lactating, they're producing milk, and one or more of the ducts gets blocked, and when that duct gets blocked, it increases the risk of bacterial growth. I mean, bacteria loves warm environments where they can feed. So they love the body secretions, and milk. Milk is something that it can feed off of. So that results in bacterial growth in the retained milk, and we'll talk about the treatment in just a second. Non-lactational, it can be caused by duct ectasia, which occurs when the milk ducts become congested with secretions and debris. And is what ectasia is dilation of the duct. So when that duct becomes dilated, it becomes more congested and can get blocked. So is what we need to teach people to look for is flu-like symptoms. They just don't feel well, their body aches, they may have warm, red, tender, swollen breast. It can be bilateral or unilateral, and they may have some cracked nipples, especially if it's lactation. The treatment is going to be oral antibiotics, Tylenol, warm compresses. Make sure that they're performing hand hygiene. Make sure that if they are breastfeeding, that they're cleaning themselves before feeding, wearing a supportive bra. And if they are lactating, again, we want them to make sure that they empty the milk out of their breast. We want them to completely empty, and the reason being is that prevents anytime there's milk left in there, that's potential for milk stasis, which can harbor bacteria. Okay, breast cancer is also known as a malignant breast disorder. It is the most common cancer in women, and it is the second leading cause of cancer deaths in American women. The etiology is environmental, genetic, and hormonal factors. The pathophysiology is unregulated cell growth beginning in the epithelial cells of the mammary ducts. It can be non-invasive, which means in situ, which means only in that area, or invasive, which means it's infiltrating. So non-invasive obviously has a better prognosis. Invasive means that it's invaded other lymph nodes, other areas of the body. Invasive ductal carcinoma is the most common form of breast cancer, and we're going to get into it a little bit more in just a minute. So the risk factors for breast cancer, the non-modifiable would be genetics, age, gender, their family history, if they've had a previous history of ovarian or colon cancer, if they started their menstrual cycle very early in life, or if they went into menopause very late. Those are all non-modifiable. They could not control those things. They could not modify them. Modifiable risk factors, if they do not have children after the age of 30, those women who have children after the age of 30 are at increased risk. Using hormone therapy, hormone replacement therapy, HRT, that puts them at an increased risk. Breastfeeding has shown to reduce the risk of breast cancer, specifically if you breastfeed for 6 months to a year. Not using alcohol, tobacco, or illicit street drugs. Healthy diet, especially a diet low in fat, and exercise by being active has decreased the risk of breast cancer. This is a slide, this table came from your book, the stages of cancer, and it specifies it to breast cancer. So 0 means in situ. It's the early type of breast cancer. It's the most treatable with the best prognosis. 1 is a localized tumor less than 1 inch in diameter. 2 is the tumor is 1 to 2 inches in diameter. It's spread to the axillary lymph nodes. 3, tumor 2 inches or larger, spread to other lymph nodes and tissues. Or 4, cancer has metastasized to other organs. So we want to catch breast cancer before it gets to the late signs. On this slide, these are the late signs of breast cancer. I don't feel like I have to read these to you, but these are late signs. We want to find it before. The likelihood is that if you have these signs and symptoms, then you have a higher stage breast cancer, which has a poorer prognosis. If you look on page 190 and 192, it shows how to do a clinical breast exam, and it also has the characteristics of a mass, and you will need to look at those pages on page 190 and 192. So we just discussed late signs and symptoms of breast cancer. We didn't really discuss early signs because really there's not many signs and symptoms of early breast cancer. This is why it's so very important for women over the age of 45 to start getting mammograms. Really, they're starting to recommend at the age of 40, women should have the choice. So 40 to 44 should have the choice in getting a mammogram. At the age of 45 to 54, they should get one every year. And then if they're over the age of 55, they should have one every 2 years. So that's the new guidelines and criteria for getting mammograms. And the reason being is because the early stages are usually found during a mammogram. Mammograms are less expensive than the version of MRI, which is an MRM. It's your magnetic resonance mammography. Your MRMs are way more accurate at diagnosing breast cancer, but they're very expensive, so they're not used a lot to just do routine screening. Your mammograms are. If they find something, they may do the MRM, and then if that's conclusive with a finding, then they would do a fine needle aspiration. to identify the malignancy of it, or they can do the sentinel lymph node biopsy, which shows if there's movement or involvement into the lymph nodes. Obviously, if it has invaded the lymph nodes, then it's more invasive, and it's going to be a higher staged breast cancer. I did find this picture very comical because, you know, like, it's so funny. Whoever thought of the word mammogram, every time I hear it, I think I'm supposed to put my breast in an envelope and send it to somebody. It cracked me up. I hope you enjoyed it too. So the treatment for breast cancer, surgery or mastectomy, it can be simple or radical. As simple is it includes the breast tissue, nipple, areola, and the skin, but it does not have the lymph nodes. So simple does not include lymph nodes. Radical is the removal of the entire breast and most of the lymph nodes. If they have a radical mastectomy, you do need to remember not to get any blood pressures or needle sticks on the infected side because they can have lymphedema if you do that. So after these surgeries, it's really important that we elevate their arms on a pillow, and that promotes lymph node drainage. And we need to put up a big sign that says "Do not stick" in whichever affected arm it is. Other therapies include radiation, chemotherapy, endocrine therapy. Endocrine therapy is estrogen and progesterone blocking therapy, so it stops the cell growth, and immunotherapy. So pelvic support disorders is any pelvic organ prolapse or urinary and fecal incontinence. It ultimately is weakness of connective tissue and muscular support of the pelvic organs. All right, pelvic organ prolapses. A cystocele occurs when the posterior bladder wall protrudes downward through the anterior vaginal wall. I've actually seen this happen. I had a woman that had hers out. It was prolapsed for many, many years. I actually walked into the room to do an in and out catheter, and I walked in there, she didn't say anything to me about it, and got my area ready and got all my supplies, and I went to just clean her up in her perineal area, and when I lifted back the sheets, I thought I had a male patient because it looked like a scrotum. So I pulled the covers back up and I walked out and I went and checked the chart again, and it was a female patient, and I went back in, and this time I had somebody come in for backup because I was like, okay, well maybe it's prolapse, but this woman's had been out for so long it had shriveled. It had dried and shriveled, and it actually had a bed sore on it. She had it there for years, and so we tried to do the catheter, and 2 or 3 of us tried and was unsuccessful, and that's how prolapsed it was. And her chief complaint was that she was having difficulty urinating, and so that pressure can actually cut off the ability to urinate. A recticele occurs when the rectum sags and pushes against, or it pushes against the posterior wall of the vagina. An enterocele is when the small intestines bulges through the posterior wall of the vagina, which happens a lot when patients strain while trying to have a bowel movement. And uterine prolapse occurs when the uterus descends through the pelvic floor and into the vaginal canal. A lot of manifestations that occurs from these prolapses is that they'll have stress incontinence, or they'll complain of lower abdominal pain, and those are very typical findings of pelvic organ prolapses. Which brings us to our next slide, urinary incontinence. I'm not going to go over this slide a lot because you've had this in previous courses, but there are different types of incontinence. You can have overflow, which means that the bladder is unable to empty properly, and therefore you have urethral blockage, and what comes out is overflow. Stress incontinence is where they have a relaxed pelvic floor. When they have increased abdominal pressure, it just flows out. Urge incontinence is when the bladder is oversensitive. That can happen with infection or neurological disorders, and it contracts, which causes the incontinence and voiding. Here's a video that you can watch on urinary incontinence. Polyps. Polyps are benign growths. They are most commonly found in the cervix, in the uterus. You can have cervical polyps, which appear after menstruation. They're usually a grayish white color. You can have endocervical polyps, which are in your multiparous women, ages 40 to 60. You can have endometrial, and the endocervical are usually a cherry red. Your endometrial polyps are rare in women less than 20, but they are peaking in 5th decade and gradually declining after menopause is detected. These are usually found on ultrasound or a hysteroscopy, which is an HSG, which I believe you've already talked about, but that's where they put that little Cathlon in, and they put the contrast dye in to see if, when we talked about fertility, they're looking to see if the fallopian tubes are open, but they can also detect these on the HSG. These patients are usually asymptomatic, but they may have some abnormal vaginal bleeding or discharge, and the treatment is going to be to remove them with forceps. They can do this when the patient's getting the HSG, or they can do it on a pelvic exam, and some people will even do laser vaporization, where they actually treat them with a laser. Okay, uterine fibroids, also known as leiomyomas, are benign growths. They do rapidly grow during childbirth years, childbearing years, not childbirth years. It is due to estrogen dependency, and they shrink during menopause. The peak age of incidence usually occurs at the age of 45. And as you can see in the picture, these are uterine fibroids, and there are different levels on which they can invade and infect. We diagnose these with ultrasound. The treatment is progesterone antagonist, uterine artery embolization, or they can remove the fibroids with surgery, or by doing a myomectomy, or do laser surgery, or even a hysterectomy. This is a summary of treatment for the uterine fibroids that you can look over. Okay, so now we're getting to the fun stuff, genital fistulas. There are different types of fistulas throughout the body. These are the ones that we're going to talk about today. Basically, a fistula means that it has created a pathway where it does not belong. So there are different kinds. The vesico-vaginal extends between the bladder and the vagina. The urethro-vaginal is the urethra and the vagina. The recto-vaginal is the rectum and the vagina. The vesico-uterine fistula is from the uterus to the bladder. So if you look at the picture, It shows your vesico-uterine, which goes from the uterus to the bladder. See right there. Then you have your vesico-vaginal, which goes from urine goes from the bladder to the vagina. Then you have your urethro-vaginal, which goes from the urethra to the vaginal canal. And then you have your recto-vaginal, which goes from the rectum to the vagina. So on these patients, really the presenting, like for 1, 2, and 3, the presenting factor is going to be incontinence. They're going to think that they're continuously leaking urine, and so we may misdiagnose it as incontinence when it's really a fistula. Out of those 4, the worst would be the rectovaginal, because that's bringing stool into the vaginal canal, which can cause infections, because E. coli should not be in the vaginal canal. Bartholin's cyst, as pictured, as you can imagine, where the placement of this is, it can be very painful. It can be a cyst, or it can become an abscess. It can have infection in it, but patients' biggest complaint is that it's just very, very painful. We'll discuss it more on the next slide. So the Bartholin cyst is due to a blockage of one of the ducts of the Bartholin gland. It possibly does have an infection or abscess development. The therapeutic management is conservative methods. So if they suspect infection, they may do some oral antibiotic therapy and see if that reduces it, or do warm compresses. But if that doesn't work, then it may require surgery. The nursing assessment is going to be obtaining a health history, get the signs and symptoms. If they're asymptomatic, it may be a cyst, but we also need to look for signs and symptoms of infection. Is anything draining out of it? If so, what color is it? Is it warm, tender to the touch? Does it have warmth and tenderness and swelling that's spreading? We need to do, and that's what we're looking for the protrusion of tender labial mass. We also need to explain everything to the patient, reassure and support the patient, and provide them comfort. Ovarian cyst. There are various types of ovarian cyst. I will not have you differentiate which one's which, but do know that the most common is polycystic ovarian syndrome, PCOS, which means that they have many ovarian cysts, and even if they're removed or if they rupture, they continue to get more. Signs and symptoms of PCOS would be increased hair distribution. They may have irregular menstrual cycles, pain, pelvic pain. They may have dysmenorrhea, obesity. They may be insulin resistant, infertility. Those are all signs and symptoms of PCOS. As far as ovarian cysts, just in general, a lot of times those patients will present with pelvic pain, cramping, can have some back pain, flank pain. A lot of times we sometimes suspect a kidney stone, but it turns out to be an ovarian cyst in females. The management of it is going to be analgesics and oral contraception, but ultimately we need to determine if it's benign or solid, and we do that by using a transvaginal ultrasound or laparoscopy and determine, is it benign or is it solid? Because if it's benign, we will use a watching method, and they'll just keep a close eye on it. Kind of how we were talking about, like the benign breast disorders, they just watch. We're just going to watch and look for any changes. But on the malignant, they need to come out. We need to remove those. So we do need to determine if it's benign versus solid, and solid means usually malignancy. We also need to rule out, because these signs and symptoms are very congruent with ectopic pregnancy. So if the patient is in childbearing age, then we would need to rule out pregnancy to rule out ectopic pregnancy. We would also refer to surgery for solid masses, or the solid ovarian cyst, and then just watch the benign. These are just risk factors for reproductive cancers. I don't think that you need me to read them to you, so I'll let you read over those. Warning signs of reproductive tract cancer: blood in the bowel movement, unusual vaginal discharge or chronic vulvar itching, persistent abdominal bloating or constipation, irregular vaginal bleeding. If they have persistent low backaches that are not related to standing, if they have elevated or discolored vulvar lesions, bleeding after menopause, pain or bleeding after intercourse, are all warning signs of reproductive tract cancers. Ovarian cancer. Ovarian cancer is so scary because there's just really no way to determine if you have ovarian cancer until it's almost too late. It is the 8th most common cancer among women, and it is the most common in women between 55 and 75 years old. The pathophysiology is most cells originating from the ovarian epithelium. As I mentioned, there's no way to screen for it at this time. A lot of times it's not able to be diagnosed until it enters stage 3 or stage 4. And at stage 3 or 4 is the reason why they can diagnose it at that point, is because that's whenever people start showing signs and symptoms of the disease. Ovarian cancer is known as the silent killer because it remains silent in stage 1 and 2, and then by the time they get to 3 or 4, it's just too late. It's too advanced. They do pap smears to screen for cervical cancer, but pap smears do not screen for ovarian cancer. So if you hear somebody say that, they are wrong. The CA-125 marker may be elevated in women with ovarian cancer, but it is not specific for ovarian cancer, so it could be misleading. Or it could be elevated because of metastasis. So if it originated in the ovaries and then metastasized to other places. The BRCA1 does provide information about a woman's risk factors, but it does not predict if the woman will develop the cancer. So it just tells them if they are at risk, which is a good thing, but doesn't necessarily say that they will get it. A lot of surgeons said if you require a hysterectomy and you have a family history of ovarian cancer, they will go ahead and take the ovaries as well. So therapeutic management for ovarian cancer does depend on the stage and severity of the disease. Laparoscopy will determine the diagnosis and the staging of the cancer, and if that does determine ovarian cancer, then they're going to do a total abdominal hysterectomy. They'll probably do perineal biopsies. It's very radical. They'll do a salpingo-rectomy, peritoneal biopsies, omenectomy, and a pelvic and para-aortic lymph node sampling. You do not have to know all that, but just know it's a pretty radical surgery because, as mentioned, this disease is not usually detectable until stage 3 and 4. And at that point, it's very invasive. Chemotherapy will also be recommended for all stages, and possibly even radiation therapy. The nursing assessment, I've already kind of hit on that. They're very vague complaints. The early symptoms, if they do have early symptoms, may be as vague as bloating, feeling hungry, fatigued, unexplained abdominal pain, urinary frequency, diarrhea, constipation, unexplained weight loss or gain. Anytime you have weight loss, you got to think cancer. Some late symptoms would be anorexia, ascites, a palpable mass, pelvic or back pain. The risk factors is really hereditary. So look at their family history. Do a physical exam. I mean, they're going to do a pelvic exam, but really, as mentioned, they're probably not going to be able to palpate anything until it's late stages. Our nursing management is really just promoting early detection. Don't ever just dismiss something as just a part of aging. Always do bimanual pelvic exams and transvaginal ultrasounds when patient is complaining of pelvic pain or pelvic area symptoms. Alright, so endometrial cancer is the most common gynecologic malignancy. The pathophysiology of it has two different types. Type 1 being the most common is endometrial hyperplasia that leads to carcinoma, or type 2, which is spontaneously appearing. So with endometrial cancer, it is the 4th most common cancer in women. The 90% of patients with endometrial cancer will have abnormal vaginal bleeding, which is a huge sign to watch for. The screening and diagnosis, screening is not routine. It's only when necessary. So if somebody is having abnormal vaginal bleeding, then they would want to do an endometrial biopsy to diagnose for endometrial cancer. The therapeutic management will be surgery or a hysterectomy, followed by radiation and chemotherapy, especially if it's at advanced stages endometrial cancer. In addition to that hysterectomy, they will probably go ahead and remove the fallopian tubes and ovaries. The nursing assessment, I just mentioned abnormal vaginal bleeding. Risk factors will include family history. And if you look at teaching guidelines on 8.2, it also talks about risk reduction. Cervical cancer. Cervical cancer has greatly decreased since pap smears have been routinely done. There has been a linkage from HPV to cervical cancer, and pap smear screen for HPV. So therefore, we've seen a lot of decreased incidence for cervical cancer, in addition to the HPV vaccine, which has decreased the incidence of HPV, which decreases the incidence of cervical cancer and decreases mortality. The pathophysiology is changes in the cellular lining at the squamous columnar junction. You can see figure 8.4 in your book for that. The management is going to be dependent upon the severity and the women's health history. You can also see box 8.2 for that as well. They may do a colposcopy to assess. The nursing assessment is we're going to look for risk factors, signs and symptoms, abnormal vaginal bleeding after sexual intercourse. A risk factor for cervical cancer is HPV, or if they have multiple sexual partners. Please pay attention in your books to Teaching Guidelines 8.3, the nursing procedure on 8.1, and I've already mentioned the box and table 8.2. So just really look over 8.2, 8.3, and 8.4 in your book. Okay, vaginal cancer is very rare. Majority is metastasized from the cervix. Squamous cell is the most common, and it usually affects women over the age of 50. The therapeutic management is going to be radiation, laser surgery, or even both, or they may do a possible radical surgery in addition to the radiation if it's very extensive. Vulvar cancer is the fourth most common gynecologic cancer. It's most common in women over the age of 60. The pathophysiology is primarily squamous cell carcinomas. The screening and diagnosis is going to be annual vulvar exams or biopsy any suspicious lesions, which are usually on the labia majora. Therapeutic management consists of laser surgery, the cryo surgery, which is where they use extreme cold temperatures to freeze off the tissue, or electrosurgical incision, or radical vulvectomy. The risk factors or presenting signs and symptoms would be persistent vulvar itching, and that would require further investigation for vulvar cancer. All right, this concludes our lecture. If you have any questions whatsoever, please send me an email so I can address any questions or concerns you may have about the content. I am going to let you go through these questions and try to answer them yourself without having the answers, and I will post those at a later date. I hope you all have a great night.